Welcome back to Healthcare Rounds. I'm John Marchica, CEO of Darwin Research Group. Today, we're diving into one of the biggest challenges in American medicine, at least I think, and that's the future of primary care. We continue to face clinician shortages, even as the population ages, and there's really more of a need for coordinated preventive care. Why is this happening? What's behind burnout and the economics and the loss of interest maybe on younger physicians? And what can we do, this may be most important of all, to help rebuild primary care into a sustainable, fulfilling, and high-value part of the system? So that's a little setup there to help us answer some of these questions. I'm joined by Dr. Greg Whisman, Chief Medical Officer at CareMore Health, an organization known for rethinking primary and complex care delivery for older adults. And so we're going to talk about the pressures facing clinicians today and how innovative models like CareMore's are proving that better outcomes don't necessarily mean greater costs. So there's your setup, Dr. Whisman. We're going to be talking big topics around primary care today. So just before we get started, thanks for joining us.
Yeah, thanks for having me. Topic near and dear to my heart.
That's what I was hoping. So let's just start with this kind of what I set out in the beginning, the physician shortage. And some say, more than 55,000 physicians by 2033. That was a stat that I saw. I've also seen much larger numbers than that. So just to kick us off, from your perspective, what are some of the things that are driving that on the primary care side?
Yeah, so loaded question. It's been predicated for about 20 to 30 years where people could see this coming. And it's been a trend demographically from what younger physicians and even younger college students really look for in a profession when they get out. They see high burnout, high hours, not necessarily shift work, and then losing a big part of their 20s to sitting in a library, not going out with their friends, and candidly being broke. And it just doesn't appeal to them. And so we've seen that trend really coming on here for a number of years, and there hasn't been a lot of activity done to change it. And there's a lot of levers that could be pulled. And so, a lot of them do need some of the backing and innovation of CMS and the government. But even the private insurers, as you see now, more of the integration into primary care clinics are trying to solve it a bit themselves. But it's been a complex issue, from work-life balance, medical school debt, which you hear some of the people coming out nowadays. I know I felt poor coming out, let alone what they're seeing now, which is double and triple what I encountered when I came out of med school back in the early 2000s. So it's a very complex issue. I do think there's some innovative solutions that nibble around the edges, because if we don't have a really educated and large primary care workforce out there, we're going to see a lot of healthcare costs exploding.
Thank you for that. We've talked about burnout a lot on this program, and workload issues, and you really kind of laid it out for the typical person in college today, and what they're looking at over the next 8 years or however many years post-college. And maybe this is a bigger question than we can answer here, but I just want your thoughts on it. Like, how much of this is due to kind of like our system or our country not valuing primary care in the way that we value some of the specialty care?
I think a lot of it, and that's where I really talk about the innovation. Some of the larger organizations have been lobbying on behalf of the specialists for a number of years. If you think about a primary care doc, and a lot of times, all of us go into CRs, but they may be seeing 15 to 30 patients in a day. About half of that's going to be ongoing medical therapy for heart failure, diabetes, and the like. If you think about it, out of maybe the 10 or 15 patients they see with those chronic medical conditions, what one admission would cost, right? One admission to the hospital is going to cost $15,000 to $20,000. And so that's going to cost a lot of money. But you might go in and be able to do a colonoscopy if you're a GI doctor and get several $1,000s, and you could do 20, 25 of them in a day. And so, we have incentivized doing procedural care at the expense of doing that longitudinal, long-term type care. And that is what I think is driving a lot of the issues. And so that's what really concerns me the most, is that we need thinkers. We need people that partner with their patients to develop care plans to keep them out of the hospital where the major expenses occur. And we need to start deprioritizing the procedural events that are discrete in nature. They can be rapid turnover. Not that those people need, to do them for free, but we've just incentivized it so strongly that it's easier to get, again, a scope done versus having a GI doctor see someone in the office, because that's where the bread's buttered. And so we've incentivized that model, and we've done it for a number of specialties, and it's come at the expense of that thought management in the clinic, partnering with patients on care plans to avoid those excess expenses.
It reminds me, actually, the last episode with Dr. David Carmouche, when we started talking about, at the very end of that episode, we were talking about the time spent with patients and how important that time was. And then, as you said, but if you're bouncing back and forth and you've got to see X number of patients in a day, 15, 20 or more, you don't have that time. And so I'm just, kind of side question, I guess. I mean, isn't this sort of what the ACO model was supposed to be all about? I'm not asking for you to indict the ACOs, but right? I mean, it was a shift to primary care, shift to value, which we're going to talk a lot about, I guess, probably in the next half an hour. But has the ACO model kind of under-delivered then? Or do you think it's kind of helped shift some thinking and move the needle on having more of a focus on primary care?
Yeah, I've developed a Medicare shared savings program in my time. And here's the thing that you run into. I've run a lot of these value-based clinical programs. And so each payer has a different program. Each one has a different, set of quality measures. A lot of them have cost targets, but you're constantly it's like whack-a-mole. It's every payer's got a program, and then Medicare's got their program, and they don't all perfectly line up. And you don't get the data in the same files to put it in one system to see who your high-risk patients are. And so it's not that the models, any one of them, are bad. It's that there is the lack of uniformity. And so you're constantly trying to meet each payer's list, and it really makes it a challenge to hit the mark. There could be a lot greater alignment, but the problem you run into, obviously, with the Federal Trade Commission is how much can you share amongst payers and to really get down to a core program. There was a lot of promise, I think, back in the late teens. There was a model that came from CMMI that was demonstrated, the CPC Plus model, that brought together payers in a consortium to identify core measurements, core skills, and the like. And so that had some promise, but the primary care has a lot of independent docs out there still. And then you couple that with health systems that are acquiring for the vertical integration in the referral downstream. And so they're hitting a different target. Again, they're hitting a revenue-based target for a health system, as opposed to let's make sure we're hitting an MLR target or a cost savings target. And so we've really incentivized, again, the wrong outcome. And so it's not an indictment of the ACO models. It's just there's just too darn many of them for anybody to be uniformly successful.
Yeah. We've been here at Darwin Research Group, we've been tracking these for well over 10 years, probably closer to 15 years. And you're exactly right. There are so many different models out there. Even if you look at the, over time, the ones that have come from Medicare, right?
Mm-hmm.
I mean, all the different models that they've put out there. But, I guess it gets to another maybe broader question, and that is another thing that I've heard is that, primary care is just unsustainable, financially speaking.
Mm-hmm.
Low margins, high administrative costs. Why is that? Well, first of all, I guess I should say, is that correct? Is that a correct assessment? Because it's something that's out there. But if it is, why is that the case?
Well, so again, the margins, so when you say the margins are low, the margins are artificial. The margins are what the system has created. If you incentivized primary care and you decrease. So Porter's 5 forces: decrease the barriers to entry, right? So instead of coming out with 300 grand worth of medical school debt, why don't we invest in a primary care workforce to keep our patients and our populace out of the hospital, and say, you come out and work in primary care, we're going to give you a 5-year loan repayment program paid for. Medicare funds the residency programs. Let's invest in the primary care workforce. Define what it means so you know who's all in it, and repay those student loans by serving our populace that is aging by the day. And so we could create the margin, because you can increase the top rate. You incentivize the behavior you want to have happen, right? We always talk about that in value-based care. If you incentivize clinicians for the behavior you want to achieve, you can achieve great results. Well, let's incentivize the workforce of the future by investing in it. And sure, there's ways to, you might say, we can't grow the pie, right? Like the health spending is the health spending, and you got to find it other places. You're going to have to shave it in other venues because, again, if we can treat the chronic disease, if you can take care and keep people on their medications, if you can eliminate some of the financial instability that lower margin specialties, pediatricians, in some markets, OBGYNs and your family medicine outpatient doc is seeing, if you can quell that and you're not worried about that, suddenly you can open up same day access, because you're not filling your schedule with 30 patients to keep the lights on. You're filling it up with the 15 people that needed to be seen today. And so that keeps people out of the emergency departments. We had a model here locally where they were building freestanding EDs within 7 minutes of every patient. Now, I don't know about you, but I don't think you need an ER every 7 minutes if you're doing really good primary care.
Right. Yeah. The McDonald's model or the CVS model brought to emergency room departments. It just seems kind of ridiculous. By the way, first guest ever. Props to Dr. Whisman for dropping the Porter model in his comments. Like, it's a first for everything.
I'm going to make the MBA professors very proud.
That's right. They will be.
Yeah.
But just one. Not to harp on this point, but I want to get back to that. The seeing so many patients in a day, and rightly said, you want to get to those 15 that matter. But just conceptually, what gets lost when you're on this treadmill? What gets lost in the patient conversation? What gets missed when you're trying to hit these kinds of numbers on a day-to-day basis in primary care specifically?
So much. So if you think about it, back when we were kids and growing up, you went in to see the doctor, they knew about your family, they knew what sport you played, they talked with you and engaged you. Some of that, personalization gets short-sighted a bit. And if not, you're in the waiting room for hours waiting on, your name to get called to go back to see the doc. So that stuff gets short-sighted. And what does that do? That's more than just shooting the breeze. That really is developing the rapport and the trust to get you to buy into your care plan. Now, I care about you. I'm looking out for your best interests. I know about you. I hear what you're saying. All those listening skills have gotten eaten up by keyboarding from the EHR. So all of that gets lost. But then I always say, the worst treatment plan. So I do some telehealth in the evenings and on the weekends just to keep me grounded, since I've been in the administrative game. And I see so many patients that'll be on particular medicines and they'll be like, is that the right one, or is that what I should be on? And it's not for me necessarily to second guess. It's to say the worst medicine that you're on is the one you can't afford, the one you don't pick up, and the one you don't take. So if this is the one you and your clinician worked out and you're taking it regularly and it's not, harming you, you're not having side effects, then that's the right medicine for you. But if you go into the room and I have no sense of your socioeconomic status or your belief that I'm prescribing you the right treatment, therapy, imaging, medication, then that is a complete lost encounter. And so we've got to have that rapport, and you've got to develop it quickly, right? Because you're going to see the 30 patients. They say docs cut people off on average after 30 seconds, and the average visit's 7 minutes. That's not sustainable. That's not the primary care we want. It's not what we grew up looking at, and it's not what's going to keep people healthy moving forward. You've got to develop that, and you've got to get that holistic perspective. It's not just the Western medicine, write a script, go through the drive-through, pick it up and take it. We need to talk about what you're eating. We need to talk about any supplements you're taking. We need to talk about your exercise programs, how much caffeine you take. I lost a patient and he came back a year later when I asked him about how much he was smoking, but how many breaks he would take during the day to drink a Mountain Dew. And he'd go out and have a smoke break and a Mountain Dew. He's drinking 24 Mountain Dews in a day. 24.
Wow.
Yeah. Well, no one drinks just one. But he was drinking 24 of them. And so his wife was my patient as well. And he came back about a year later and he's like, well, you're right. And he was about 30 pounds heavier. And so we worked with him on that, but just the caffeine and the sugar. And you've got to get to that level where you can sit there and you can talk about, okay, what's your average day like? How many breaks are you taking during the day? Because that's how you find out how many smoke breaks they were taking, how much you really smoking. And so you got to get to that deeper level. And the other thing I'll put a plug in for any of the CFOs that are listening here of any of this conversation, I know how much our docs and how much I can do in a visit, right? 15 minutes, 30 minutes, you call it. But there's so much of care that takes place in between those visits. And that's when your care navigators and your care managers can outreach to patients and help guide them and get them to the right avenue, make sure they're picking up their meds, make sure they followed up on their testing. And every time we go in a room and you go through a budgeting thing, they're like, well, how can you prove what that case manager did and the ROI attached to it? And I say, I know what they did because I'm seeing the patients and I know my gaps. But it's really hard to tell a CFO the expense that they didn't have. And so it's constantly very strongly scrutinized, but I've got to put a plug in because it's more than just the doc in the room with the long coat. It is the team that supports them that can keep the people healthy.
Wow. Well, I mean, isn't that also part of the financial challenge that some of those are fixed costs or, viewed differently within the system than the ones that may be RVU based or something along those lines? So then, that gets to be challenging, I would say, for those CFOs. But that makes me think of it. And please, I know this is going to sound like a master of the obvious question, but it also could be an incredibly technical response. And that is, well, what about technology?
Mm-hmm.
Like how well, and maybe if you have a specific example, like how well can technology get us there? And again, this kind of harkens back to the last episode when we were talking about this with AI. How can technology help make these numbers look better and allow to get to that, maybe 15 is the right number, 12 to 15 patients a day. Imagine that.
Yeah. It's an enabler, right? And so I was just having this conversation about AI on in another forum, and it should be an enabler of the care we want. You've got to ask yourself, and there are those cases where the AI, one of the AI venues was acting as a therapist, and there was a teenage boy that was expressing suicidal ideation. We don't want that person talking to a chatbot. We want that person talking to a live thinking human being. And so we've got to find a way to balance the two. So it's an enabler. It's not the solution. It should enable the workforce to work smarter, not harder. And I use the example of, all of us love our electronic medical record, tongue in cheek. We're all we're all secretaries a bit to it. And you could enable AI that should put the abnormal lab results at the top of your dashboard with the blinking red light. It should tell you, like, here would be the test you should order based off of these three things so that you are doing faster administrative work so you become more efficient. And so you're not taking it home at night, again, getting to the younger workforce being a little more attractive to, but you also are working to be able to get patients in because you are not messing with the computer as much as you historically have been. So it can be an enabler. The other cool thing when you think about it, and out of all the things COVID did to us, it did rapidly expand on telehealth options and people being more comfortable in, a two-dimensional space for acute needs. I do see patients that sometimes, say, well, why can't we just do this all the time? And you got to put a stethoscope on people. But it does allow us to take care of routine, simpler type visits in I think they call it an asynchronous or, a two-dimensional space here through the internet. So there are things that can be done that are novel and breakthrough that can help with efficiency, can help with work-life balance, can bring those low acuity type visits to a discussion that's much cheaper than going for the $1,500 ER visit. And so you can have a multitude of those things. But ultimately, I believe, and I am biased, but people like the touch and feel of going to see a doctor when they're hurting, when they have something. And I say doctor, I mean, we've got, primary care nurse practitioners as well. I will group them in as well. But there are things that you need to go see and discuss and talk through. And so I don't think it'll ever be a true replacement, but it should be an enabler, and we should enable these type experiences. And that should be rewarded as well. So for case management, for instance, if there is an encounter that happens, through a computer or something, like, you should be able to bill for certain discrete encounters unless you're in some sort of like capitated model.
Right, right. Well, and anecdotally, but also I think some studies out there suggest that patients prefer that, when they can, because it's for just simple matters of convenience, right? Yep. That if it, as you say, it doesn't completely replace the face-to-face visit, where you can do other kinds of assessments, but certainly is a way that that COVID, I think in a lot of cases, it was like emergency stand-up telehealth systems because we don't have one. Yeah. I remember actually my wife was part of one of those at a health system at the start of COVID. They didn't have anything, and they needed to have it put in place like pronto. So that's so. Let's switch gears and let's get into CareMore a little bit. I want to learn more about the organization. You're leading clinical strategy. And so maybe just to start us off, talk a little bit about the model and the populations that you serve.
Yeah, no, love the question. So CareMore, so we bill ourselves as an advanced primary care group. And what that means is we take care of the chronic and complex. So we're focused predominantly on geriatrics in our Medicare age band that have multiple chronic conditions. We're about 40 to 50% SNP, meaning we've got special needs plans that we cover. Predominantly, we're out in the Southwest, Arizona, Nevada, and California. And that's where we're taking full risk or capitated. And we're able to really manage those lives A to Z. So we have line of sight to them when they're in the hospital or when they've even hit the emergency department. We get data feeds. We're able to reach out to them, make sure they don't get readmitted, make sure they're getting into our clinics. We get all their pharmaceutical information, so we're making sure that we're reconciling their meds on the flip side, so we don't double up on people's medications. A lot of times that happens right after someone's hospitalized. And so we really have that full risk, full picture, care across the continuum type mindset. Now we've got, a very socially, economically depressed population. So they have a lot of needs. So we've got social workers. We have clinical programs that enable us to really link them with meals and services in the communities. If we can make sure that we're dropping off their meds or dropping off resources to them, we try to hit them in all venues. And so we've got some homeless folks. So sometimes it means going into the shelter. We've got mobile teams that go and visit the patient at home when they can't get to us. So we really do cover kind of healthcare A to Z, all the continuum, and try to pick people up where, they tend to fall down in a typical fee-for-service type payer arrangement.
So you're all hands on deck. I mean, you're really looking at this specific challenging, we'll say, patient population, and deploying every, human and technology that you can to be able to, I'm assuming it's not just better outcomes, but control costs. So walk me through, let's just take, pretty typical older adult with diabetes and heart failure. There you go. That's maybe throw in a little obesity. So trifecta, right? How would your approach be different? Let's just take this a little case study, a little model here. How would your approach be different than, say, the standard primary care model that older adult would get?
Well, so the first thing is you're going to be impaneled to not only a doctor, but a case manager that's going to be outreaching to you to make sure that you've got your gaps in care closed, that your appointments are scheduled at the regular cadence. In that type of example, you're probably going to be seen every 3 to 4 months to make sure that you get all your appropriate blood work done and managed. If you hit an emergency department, I'm hoping that's because we directed you there. You called us first. So when we're not available, so after hours, 24/7, we've got our own nurse practitioner staffed telehealth service for our patients. So you are outreaching to CareMore, and we can guide you to the emergency department if it's an acute need. We can free up a slot to get you in ASAP if you need to be seen. But we've got that case manager attached to you in between those visits in our clinic to make sure that all your needs are being met. If you have questions, you are calling us first. In a standard clinic, you're going to come in and see me. I'm going to write you for your scripts. And about once a year for that CHF patient, they're going to go in likely to see a cardiologist. Now, if you're like a lot of, geriatric patients, they take that script from the cardiologist and then they come back and see me and they go, he or she wanted me to do this. What do you think? Because we've developed that rapport as the primary care doc. And so, which is wonderful and rewarding in and of itself. But you're seeing your clinician every 3 to 4 months throughout the course of that year. And in between, it's kind of on you. And the only other outreach you have is either you call the office and leave a message on our nurse line. And I think we've all probably done that and gotten the 24-hour turnaround. And, they tell you to maybe come in or, oh, you've got an appointment coming up, you're fine. Or you've got the nurse line on the back of your insurance card. Those are your only lifelines to navigate 3 complex conditions that dramatically impact your quality of life and your life expectancy. And that's what we're expecting to support you through that. And you add CHF in there. CHF is one of the main drivers of not only hospital admissions, but mortality and significant morbidity to patients. I mean, they're short of breath, they're swelling, they have to watch everything they eat. I mean, it can be a really, really tragic disease to get. And so a lot of it's preventable, but you've got to have that close contact with your care team. And I think that's what we provide is that team of services that are going to wrap around you, meet you where you're at, but help to educate you about your disease process as well. And I'll tell you, just as an aside, we've seen, 40% SNP membership, even in our iSNP patients. When I talk to other groups, and these are institutionalized folks, people that are, in a long-term facility that require, hands-on help, and we're sending nurse practitioners and doctors in to see them. Our admission rate, like our admissions per 1,000 patients in that population, when I talk to a lot of these other provider organizations, we're 100, 150, 200 less from an admission perspective on that population than I'm hearing what they are. And that's because of the total wraparound service that we're able to provide to really support the patient that has the most critical acute needs.
Well, I think in part you answered my next question, which is, you talked about certainly in the ACO model, you have all these differences and what kinds of things that they're focused on, what kinds of quality measures they may be focused on, or contractual obligations. What are if I know it's going to be different for each patient to some degree, but what are the success measures that you look to? You gave me a great example of one, but are there more, global success measures that CareMore looks at? You're doing well.
Well, so I'm going to start off with obviously my biggest pet peeve in the entire health system, and that's your readmission rate. I view readmissions as just a failure of the whole health ecosystem, not just one failure point, but it's a lot of failure points. So, I almost think almost all readmissions should have at least been intervened with and done everything to prevent. Worst thing you do is send someone back into a hospital, run the risk of getting sick, run the risk of injury and the like. So we monitor our readmission rate very strongly and influence, because I think that's one of those really key things that these value-based organizations can influence at a more ready level, because you're capturing the patient once they hit, home after being admitted. You're capturing them, getting a hold of them, getting them in, get them seen, get their medications reconciled. Much more ability to influence than per se just the admissions per thousand that we look at. But the number of admissions obviously is a benchmark. Admissions are very expensive, but they are subject to, for instance, we saw a big blip in respiratory admissions from the wildfires in California. There was a bad flu season last year, so we saw a blip in that. Those were two things we couldn't control, but we could try to influence and make sure people had their medicines, give them early refills and the like. So we monitor those very closely. For us, we are very deeply entrenched in the MA model. So we watch our stars ratings to make sure that our seniors are all getting their gaps in care closed. So those are really big, indicators of how our finances are going to flow. We obviously have total cost of care targets, so our overall health spend. We measure that, and we've got MLR targets we're measuring too. So we look at all those are from the financial standpoint, but then we look at things like our Net Promoter Score to make sure that we are engaging our patients, how our patients feel about the care they're receiving at CareMore. We're going to be implementing a new patient satisfaction survey next year that allow us to really gauge how our providers are doing in providing the care. And so I think all those are really critical. And then the last thing I would say that we really, we've taken a strong indicator to is over the last year, we've removed like 70,000 codes off of prior authorization to make us easier to do business with. And so we continue to evaluate that. We want to make sure we're reviewing the right things, that we've got good guidance on it, but we're removing barriers to low cost things that don't need to be reviewed and we just stand in the way of, but also to make sure that we're reviewing the right things that tend to have some fraud, waste, and abuse in the system. We're able to capture that right away. So we're eliminating some of those extraneous costs in the system. But we're trying to do it in a smart way. And you mentioned AI earlier, and that's one of those areas that I think tech enablement can really help.
So how scalable is your model? I mean, if you've got a lot of people involved, you mentioned, I think, sort of regional focus, at least at this point. How scalable is it for this kind of population across the country? But then I'm also wondering, what lessons can be learned from this challenging population that you're focused on, right? What lessons can be learned from that to the broader population of, in the primary care world? I know there's a lot in that question, but I'll take what I can get from you.
Yeah, I would say, well, look, I mean, it's scalable because everybody's in the business working on it, right? You see the Oak Streets, you see the Chen Meds, you see a lot of these high acuity type clinics. So I think the model in and of itself, and I think what we do really well with it is we've got delegation for the utilization management of it. So we see the patient when they're head in a bed in a hospital and can work with the hospital in their discharge, where some of the other groups have a bit of a blind spot during that period. But if you've got and so the capitated model supports all that administrative overhead. Now we've got to do some things like make sure that we're appropriately coding and identifying our high risk patients and the like to support that. But when you have this type of population, it lends itself to that kind of management. And that's how we're going to bend the cost curve on the high risk elderly patient. But what's, I think, portable is the need to be able to identify high risk patients in every population. So if you think of, just being in a normal, maybe an affluent community or, a middle-class community, you still want to be able to identify who are the people that have hit the ER a couple of times that are percolating with, some high blood pressure or some bad lifestyle choices, so that those are the patients, those 15 that you want to get in and see on a given day are those people that are rising to the top. Because it's really hard. I once saw some statistics back at a previous role where that top, everybody said, oh, you got to manage your top 5% of healthcare costs. You manage that top 5%, those people that are constantly going to the ER, you manage them and you're going to, make money as a group. Well, it turns out the 5% changes every year because that type 5%, most of them are critically ill. A lot of them do pass within the course of that year, or they had a cataclysmic event, a car accident or something that bumped them up in that. And the next year, it's a different 5%. So you've got to manage those people that are blooming, that are just kind of smoldering right below the surface. And you need some tech innovation there to risk stratify and a method with which to engage them. And it doesn't always mean they have to come into the bricks and mortar, but you have to find a way to connect with them before they start driving your health costs by hitting the facility. So there are ways to do it. In the commercial population, it gets a little tricky because cancer, trauma, and low birth weight babies drive a lot of the variation in spend in a commercial population. But it's got to be a better way to manage. And you see it with the FQHCs, but our Medicaid population, which has been growing and had its challenges, and certainly our seniors, where pop health is so critically important. These models, I think, can be a giant tool in how we begin to bend that curve.
Excellent. Dr. Whisman, before we get to our lightning round, one of my favorites to do at the end of all of this, I want to come back to where we started in the conversation about shortages, burnout, kind of issues that people in med school are even deciding whether to go into med school or not, right? So my question is, to make primary care, let's say, a joyful career again, to make it desirable, what changes do you think need to happen? Here's your magic wand, right? To make it desirable. And that, by the way, that's not just physicians. That's nurses, as you say, NPs, to make this primary care focus, to make it desirable and joyful, what needs to happen?
So what was it? It was the great James Carville back in the day saying, keep it simple, stupid, right? Or is it's the economy, stupid? It was one of the two. But, so we've got, what are the big things that are driving 20-somethings into other fields? One, they get immediately recognized and income. So let's pay our residents a living wage because they're working 70 to 80 hours a week. So in their 20s, they feel like they got a little pocket change. Let's defer their payments on their loans while they're in residency. And then let's do a payback period to get them out into practice. So now I've eliminated a little bit of that, that mortgage for the condo in Boca that you never see because it was called med school. So you've eliminated a little bit of that albatross, and we've all paid for that, and it stunk. And then let's work on that work-life balance. So what you do is you start talking about, okay, is there a cap rate? Is there a panel rate? So if you come out and you see, instead of having 2,500 patients as your panel, you have 750, and we pay you for that panel size to manage them. A to Z, soup to nuts, manage their care. And when your panel's full, you get back in. And you do that across payers. So it doesn't have to be a one payment system, one payer system that a lot of people, like to spin their wheels about. And so we make it so that you have a manageable patient population you're taking care of. And we give you objective, whether it's annual, quarterly data on the performance of that. So, if you've got 11 payer groups or whatever, let's integrate that through either one of these healthcare alliances in the community. So you get one reporting on your patients each year. Let's aggregate the data. How many admissions did you have? Who, wasn't taking their medications, those kind of things. But decrease panel size, decrease debt, and let's reimburse at some sort of cap plus rate. So cap maybe plus, acute visits or whatever you want to see. So let's reinvest in that evaluation and management, maybe at the expense of some of the CPT or procedural based, cost basis that we're paying people for. And so you've incentivized them, you've eliminated a little bit of their debt, you've managed their work-life balance with a little bit less that they're doing each day. And let's start looking at a little tech enablement to help them manage the EHR albatross that was, 15 years too early layered on them. And I think you'll start to turn the tide a little bit. The other thing I think we have to do, and it's probably on my colleagues and I as well, we need to be better ambassadors for primary care. We need to sell them. I mean, if you think about it, the 60-year-old clinician that's out there got thrust in EHR that wasn't ready for prime time, put in a value-based model or payment contracts, had to get gobbled up by a health system to remain viable because we undercut what they were being paid, and they haven't had a raise from a major payer in years. And we expect them to go out and tell their kids, yeah, go into primary care, it's great. We're not doing that because we haven't painted a picture of what this should look like in 5 years and why you should get excited about doing it. And we need to get back there. So we got to be better ambassadors about it. And I think as a community, the people that aren't primary care doctors, the people that aren't doctors. There's a lot of suspicion about anybody that, makes six figures or is wealthy nowadays or anything. But if you have to have a pillar in your community that you aspire to, or you say, how about it's someone that takes care of people? Let's pay our nurses and our doctors well, because we want them not to be stressed and bring in their drama when they come in to take care of me when I'm sick. So we got to believe in somebody in our community. And I like to believe it's someone that spent a plethora of their time in their young life trying to learn all they could and take care of people. And so I think we've got to get back to actually having a little support and discussion about what we hold dear to us, rather not than an influencer on a phone. It's actually somebody that's making a difference in people's lives.
You're inspiring to me, Dr. Whisman. Fortunately, I'm a little too old to be going back to school and doing these things. But, I would think, there's a lot of data out there that suggests that, Gen Z and millennials, while my generation is still trying to figure out how to manage, how to lead and all of that with this generation, the one thing that just keeps coming back is this desire to make a difference. This desire to have meaning in work, right? And so I feel like I love your concept of ambassador and being able to tell this story, but then it has to be backed up, right?
Amen.
If you're painting that picture, then I almost think like it may even be the individual health systems or that are able to move the needle to say, here's what the experience is like working at, Advocate, or here's the experience at Mayo Clinic that would be a bad example in primary care, but you understand what I'm saying. Like it almost has to come from the institutions themselves that are maybe employing a lot of these to say, you can make a difference, and here's how, being a part of our system is different. Anyway, as I said, quite inspiring.
They want to make a difference, but what comes in like number 2 on that list is work-life balance.
Yes,
and
absolutely.
That is the picture that we're not painting. We're giving them a picture of, I take 2 hours worth of home of documentation at night. And so they see that and they go, I want something that I turn off at 5 or 6 o'clock and maybe stop for happy hour with my friends and go home. Like they want more of that kind of framework. And so we've got to find ways to get that work-life balance for them, really for all of us. It's what drove the burnout crisis, and it's what's driving people away from picking what is a really meaningful career, because we make it intimidating. Mountains of debt and a whole lot of not free time. I don't know why people aren't just, jumping at that opportunity.
No, that's really important. That your point about that work-life balance is absolutely essential. I wonder how much, and you don't have to answer this, but how much of that residency process and how much of that, medical school or latter medical school experience is about weeding people out and about keeping people out of the profession versus supporting the medical student to get through. Yeah, I understand they're really long hours and can be pretty brutal, but how much of that is, I don't know, we're just going to limit the number of doctors, and so we've got to make this a particularly arduous and difficult process to keep people out of the profession. I don't know, that sounds a little cynical, I guess, the way I framed that.
Residency in med school, there's really no weeding out. That's what the undergrad, pre-medical curriculum does pretty darn well. They call it organic chemistry, and it weeds plenty of people out. But by the time you get in the med schools, they're really held accountable for their passage rates, their residency match programs. And once you're in residency, every program wants to support you. But it is a lot of hours. And I will say it's a lot of times cheap labor for the health systems because it's paid for by CMS. You're basically paying a minimum wage. I think the residents, I know when I was in there working 80 hours a week, it was like $42,000 for like 3 years. So, yeah. So we're on call 24/7, staffing the admissions. And so it's a cheap workforce, if you will, for the hospitals. And so I think that's a little bit of the issue there, is that it's a lot of work for not a lot of money, and you do miss out on some things at that time in your life. It's kind of the best time of your life, but at the same time, you're sleep deprived and poor.
Well, and now we're really getting a bit off topic, but I'm just going to say I wonder how much of that is also due to, I don't know, say a shorter term focus among folks that are in their 20s and they're in college, that just kind of through technology and other shifts, just people thinking very much so short term. So maybe 20 years ago, somebody would say, well, I know it's going to be, 4, 6, 8 years of pain and a lot of work and but here are the rewards longer term. And maybe today people just don't have that same kind of time horizon that they're thinking
they're cynical, aren't they? I mean, nowadays, they're the COVID generation. They've, dealt with a lot of maybe broken trust from institutions. So they don't see that long time horizon. Right. And so we've got to get back there in general.
Sure. All right. We could keep talking. Like literally my list of questions, we could keep going on and on, but I know that Vincent is going to start saying, hey, time. So let's get into our lightning round. All I'm looking for is a short phrase or word to these questions. Okay. Sure you're familiar with the format.
Yep.
So first, what's the most misunderstood aspect of primary care?
I would say the empathy, the compassion. We don't want to spend 7 minutes with people. We want to spend more.
One innovation that makes you optimistic about healthcare?
The next generation of EHR. I think the inbox aggregators are going to be life-changing.
A book or thinker or mentor who's influenced your leadership style?
So Dr. Ed Bope was the longest serving family medicine residency program director. He went to the VA. He's a skilled author of medical textbooks, but really just a perfect servant leader, and really inspired me in that vein.
The biggest myth about value-based care?
That it's not sustainable.
And finally, if you weren't in medicine, what would you be doing?
So, I always grew up thinking I wanted to be president of the United States.
There's still time.
There is time, but boy, did they do a good job of not making it look appealing. So if you think primary care looks rough, look at the White House over the last, it doesn't matter party, last 25 years. Boy,
toughest job.
They can beat somebody up that even thinks about it.
Yeah, I hear you. Well, this has been great, Dr. Whisman. Very fascinating conversation. Before I wrap this up, where can listeners learn more about your work and the broader CareMore mission?
So they can find us online. They can find us at our LinkedIn sites for CareMore, or they can look me up on LinkedIn, and certainly communicate and reach out to us that way.
Well, thanks again. Much appreciated. And I hope to have you back and cover some of the myriad issues that I wanted to talk about. But this was really great. Thanks again.
Happy to join anytime. Thanks for the time.
Well, that'll do it for another episode of Healthcare Rounds. I'm John Marchica, CEO of Darwin Research Group. Today, our guest has been Dr. Greg Whisman, Chief Medical Officer at CareMore Health. If you enjoyed today's episode, please take a moment to rate the show on Apple Podcasts, Spotify, or wherever you listen. And if you haven't already, follow us on Healthcare Rounds on LinkedIn and YouTube for more insights from leaders shaping the future of healthcare. And we'll see you next round.